Honorable Dr. Sharma, past Chairman Haryana Homeopathy Council Haryana, and respected doctors, we have come to us from different places. I welcome you all on this seminar on clinical cardiology, where we will discuss. It is an audio-visual seminar to learn, to enhance our clinical skills, to make the proper diagnosis without the echocardiography, without angiography, without CT scan, with the MRI. There are different things going on in the hospitals. We don't need them. If we are clinic, if we use our eyes, if we use our ears minutely focused on the patient, you can make 80 to 90% of the diagnosis. And when the diagnosis is properly made, and if we know the clinical insights in the going on in the patient, whether it is a valvular heart disease, whether it is holes in the heart, whether the pulse has gone down, we can cure the patient. This is my experience in the past 30 years. In 1996, I passed out in 1994, and after that passing out, I started my self-study of the cardiology. I bought many books, went to Delhi, imported many books, and then later on 1996, I got this learning program, audio-visual program from USA, and started learning it, and that I am going to share with you. Hope you will love it and enhance your skills to do the best to the patients who are suffering in cardiac diseases. First of all, I would like to honor Dr. Sharma for making such a wonderful arrangement. He is master of ceremonies. I am watching him since last 40 years. Before even I went to homeopathy college, he has been organizing a lot of seminars in GMN College, in Rukmini Devi Hall. I have been attending almost all the these programs, and I would like to request him to come here. So I'd like to honor him. नहीं ये तो जरूरी है जी. आ जाओ आप. नहीं पकड़ा. What homeopathy has to offer the critically ill patients of different heart conditions? Can we help a case whose heart is working only 15%? The whole body is swelled up. The authority hospitals like PGI, Fortis and Scots, they have said nothing can be done. A few years back, around, a lady came to me. She was in this condition. His son came to me, bring her to me in an ambulance. Doctor, what can be done? Can you help us? I found out only 15% heart was working, whole body swelled up. Okay, yes, we will help you definitely. And you will wonder, with pulsatilla, I could save the life. How we will know about pulsatilla? Pulsatilla, if you want to know the real power of pulsatilla, you have to study Materia Medica Pura, Volume 2, and you get connected with it's a very powerful medicine, for powerful cardiac medicine. Another case came to me, the pulse was 36 only. A lady around 40 years of age, when my pulse has gone down, complete heart block, they say immediate pacemaker implant by the PGI Chandigarh. And I don't want operation, I don't want pacemaker, can you help? And you will wonder, in a period of 8 months, his pulse came down to normal. That case I did with Carbovec, 3 doses in a period of 8 months. It does not matter I have done with one medicine or another, you can do it in the mother medicine, But only thing is that it is curable. That is the message I want to share with you. Another case, a Mary Peter multi-wall disease case, and they PGI recommended multi-wall replacement, aortic wall, mitral wall. We have to change. She said no, I don't want operation. She came to me, took treatment. I need. I gave her some series of medicines. Not with one medicine we cannot cure the case. One medicine, another, then third. We have to go in succession, but not combination. I am a pure Hahnemann prescriber. I go by the words of organon and chronic disease. I go with that. And it took me 2 years to heal that case. And again, echocardiography was done, and they said there is no need of operation. Another case came to me with hole in the heart. A 7-year child, father came to me, even his child could not walk. Came to me in lab, गोदी उठा के मेरे पास लेके आए, blue lips. Doctor साहब, can you help? Sure. And we could do it. But I could do it, these cases, because I have thoroughly understood the cardiology. I got 20-25 books I studied. I studied learning programs and in-depth understanding of the organon prayerfully. This is very important point. Dr. Hahnemann, there was a conference in Hahnemann birthday was celebrated in Vigyan Bhavan, New Delhi. And there Dr. Hahnemann was given a status of Mahatma. Okay, in India, we call him Mahatma. He's a great soul. Mahatma means great soul. Dr. Takeshwar Jain, he was speaking. I listened to his introduction. He said he's Mahatma of India. Mahatma in Germany nobody knows, but in India we call somebody a great soul. He is Mahatma. So we have to, if we read his life history, you will see he is a very man of prayer. He always talk of God but his religion, he said, my religion is love, natural love. He had infinite love for the whole humanity. Generations will come and his love will never end. His life, everlasting life he has achieved. We are celebrating his birthday. That he is with us. He is alive. We don't celebrate birthday of other people, but he is alive with his writings. Every word we read, every word we practice, we see it is true. It will remain true. Only thing is that we don't have the courage to practice. When he says, give the medicine and wait for 90 days. No, 90 days, how we can wait? We cannot wait. We don't have even the courage. कुछ हो जाएगा, कुछ और दे देते हैं, कुछ कैंसी बदल देते हैं, कुछ ये कर देते हैं. मतलब it is our weakness. We don't follow him. We don't follow it. You need a exceptional courage, a strength of mind to read and follow his writings, and the writings are true forever. I studied organon, chronic disease, word by word, prayerfully, and with the blessings of Master Hahnemann. Whenever these cases come to me, I ask him prayerfully that Lord Hahnemann shows the way. And he said, follow my path, follow my writings, and you will achieve the success. And all the success, whatever I have achieved in these cases, is through the following this path. Now the question I put to you, I have tried to give the answer that homeopathy has an answer for all the critical cases. But the very important point is you must know the clinical insights. The training of the homeopath should be of the level of MD cardiology, MD neurology, MS ophthalmology. With all the branches, clinical branches, doctor sitting, we could speak with confidence that we understand this case and we can do it. Homeopathy is a medical court of last appeal. You will get cases not in the first stage, but in the last stage, when The allopathic hospital say, no, nothing can be done further, seva karo. Then the patient comes to you, and at that stage, you are to fight to save his life. Saving life with love, with affection, and a power comes in you, a wisdom comes in you, and you can win over the, you can really help the patient if we know the knowledge. But it is our not, it is sometimes you can say we have bad luck, or you can say the government does not give us the opportunity to homeopath. If I want to get a degree of DM cardiology, nobody will give me, but patient will give you degree. When he will get well, when he will get relief, he will say all to them that I got relief from Dr. So and so, you also go to it. The degree will be awarded with the from the patient. From these words, now let us start our program, seminar on cardiology. This is the position of the heart in anatomy that we are going to study, basic anatomy. This is, you can see, this is the right atrium. This is, this from here you can learn. This is right atrium. Then this is the position of the right ventricle. This is the position of the left ventricle. This is pulmonary artery. Left apex is in the fifth intercostal space. You can see 1, 2, 3, 4, 5. Up, if this right atrium gets enlarged, then this will move to this side, right side. If left ventricle enlarged, it will move to left side. Suppose we are seeing an X-ray. If we know that left ventricle is, we are seeing the image enlarged. We can see the left ventricle is enlarged. If we see the X-ray, this is right ventricle, and this is pulmonary artery. This is just a frontal chest anatomy. Just I am sharing with you. We should know what is the position of the different chambers in our body. Normally we are studying the 4 chambers, but we must know exactly which is the right atrium from the right heart border, left ventricle from the left heart border, and this is the apex beat. Apex is fifth intercostal space in the mid clavicular line. Up, you sometime you are to check the apex beat. Where is the apex beat? How can you have to check? Close your fist. Close. Put 2 fingers here. Press it. Can you feel some pulse? Hi, Dr. Sapiji. Can you feel? This is the feeling of the apex beat. Can you feel, Doctor? In the left lateral position, put the patient in the left lateral position and put your fingers on the apex area. You can feel the beat. Apex beat you can feel, the apical impulse we also say apex beat you can feel. And if the heart has enlarged, this position will shift from fifth mid-clavicular line, it will go towards the lateral side. It will go this side. It will go this side if the heart is enlarged. Up, suppose that is a case of left ventricular hypertrophy. If the patient is having left ventricular hypertrophy, you will see the apex beat will shift its place to the lateral side, and your 2 fingers put him on the left lateral position. Only then you can feel the apex. If the patient is straight, you can't feel. And that left lateral position, the apex moves little forward. If this right ventricular, left ventricular hypertrophy, I have told you, if the right ventricular is enlarged, in cases of we study mitral valve disease case, then this, if just put your hand like this, it is on the sternum right side. You can feel, this hand can feel that his right ventricle is enlarged. Hypertrophy of the right ventricle can be felt with the hand. No X-ray, anything we don't have. Only with hand we can diagnose if the right ventricle has enlarged, or it is, why right ventricle is enlarged. If the blood is going from the right ventricle to the pulmonary artery, in case of wherever there will be high vascular resistance in the lungs, pulmonary artery is taking blood to the lungs for filtration. If there is pressure is high, in that case the right ventricle will be enlarged. Hypertrophy of the right ventricle will, how will you detect? Just simple, put your hand like this on the right side of the sternum and you can feel the thrust. The word is thrust, धमक, धमक जिसको के बोल देते हैं, धमक होगी, ऐसे धमक, you can feel the thrust of the right ventricle and you can say the patient is right ventricular hypertrophy. By knowing the anatomy, by simple examination of fingers, this hand, you can know whether the left ventricle is enlarged, whether the right ventricle is enlarged, you can detect. No need of echocardiography, no need of any other test. With simple examination, you can know the enlargement of the hypertrophy of the left ventricle or right ventricle. So this is the anatomy I will discuss with you, and it's practical. Now this is the, now we have come to areas of auscultation, from where we will put our stethoscope to listen the sounds. One is, this is aortic area, it is second right intercostal space. Second right, you see the 1, 2, 3, 4, 5, this is second intercostal space. On the right side, this is written aortic area. If you put stethoscope here, you can listen the sound in the aortic area. There are two heart sound, first sound and the second sound. The second sound is very clear in the aortic area. It is when the semilunar walls of the aorta they get closed. We will listen actually the sounds also, but this is the aortic area for listening the second heart sound, second heart sound. Then this is pulmonary area. This is lower left sternal border. This is apex. Now I will discuss what we will listen. In the aortic area, normal sound is very low. If it is accentuated, put a stethoscope, बहुत जोर की आवाज आ रही है. Accentuating of the sound. In what state you will find accentuation sound? If the blood pressure is high, patient blood pressure is 180, 170, age for 30-40. When the blood pressure is high, the aorta has to pump the blood. It is pressure. In that case, accentuation of the aortic sound you will listen. If the blood pressure is high or the arteriosclerosis condition is there. Normally in hypertension, if the patient blood pressure is high, going on, he does not know. Hypertension is a silent killer. He is having blood pressure 5 years, 10 years. He doesn't even think I was all right. Suddenly, if he has come to you कि मेरे को घबराहट हो रही है, something, BP check कर रहे हैं, कुछ भी we find. We have to link the observations. You will check the BP. If you find the BP is high and at the same time your aortic area accentuated heart sound. Second comes, इसमें there are other sound also. Aortic stenosis will listen here. What is narrowing of the aortic wall? If there is narrowing of aortic wall, you will start listen the sound aortic stenosis. If there is regurgitation, if there is leakage of the aortic wall, then you can listen the sound here in aortic area. Next comes the pulmonary area. In pulmonic area, if the pulmonary hypertension is there, if the lungs vasculature, the pulmonary vascular resistance is high, there will PAH, pulmonary hypertension, PAH. Where we will find pulmonary hypertension? You will find it in cases of mitral valve disease. We will study further what is mitral valve disease, how the pressure goes up. We will discuss that. But if the pulmonary hypertension is there, if the case is of pulmonary hypertension, the accentuation of the sound you will listen in the pulmonary case. If the sound is high, you can write down the accentuated sound. It may be having pulmonary hypertension. But we will have other study further. What are the other symptoms also? We will link different observations to make our diagnosis confirmed. Third is lower left sternal border. In the lower left sternal border, there are sounds tricuspid regurgitation. This is the area over the tricuspid wall between the right atrium and the right ventricle. Tricuspid regurgitation is there. You will listen the sound at the lower left sternal border. I will show you this sound also. You will listen all of them. There is another sound. What else you can say? Ventricular septal defect, tetralogiocephalate. The sound will be very loud, very loud sound, and you can listen the sound all over the front and all over the back also. It is such a loud sound, VSD sound. If you listen that sound all over the chest, all over the back, in the lower left sternal border, immediately you can write the VSD. Simple. By listening the sound, we can make the diagnosis. What is the need of sending him to the go for apex? Apex is the main area where I have just told you that we will know the hypertrophy. In apex, we will listen the sound of mitral valve disease. The mitral regurgitation is there. Mitral stenosis is there. Hypertrophy of the heart is there. Left ventricle hypertrophy is there. You will listen all these sounds in this apex area. What are the character of the sound? We will study further. I have just told you that we will listening such type of sounds in these particular areas. Let's we move ahead. Now we are studying the cardiac cycle. Cardiac cycle we all know. You see the blood is coming from the left atrium, going to the left ventricle, and from left ventricle it is going to the aorta for circulation. This is cardiac cycle. Now we will study the sound step frame by frame. This mitral valve has opened. Blood is started coming from the left atrium to the left ventricle. Then the first opening, you can see the yellow, the blood is going. It comes to the left atrium to left ventricle in 3 stages. This is the first stage you are watching. Stage is, you can see that blood has started, mitral valve has opened, and blood has started flowing from left atrium to the left ventricle. Second stage is diastasis. 3 stages I have told you. The blood is flowing from with a speed to the left atrium to the left ventricle. And the third stage is atrial systole. Then the atria contract and the final whatever blood is left in the atria, it coming into left ventricle. Now next stage what will happen? The atrial wall will close. Now let us close it. Can you listen the sound? This is first heart sound. First heart sound is the closure of the atrioventricular wall in the left side, atria to ventricle. This is left first heart sound. Listening first heart sound. This lub dub. This is two sound. This is first heart sound which you will listen at the apex. First heart sound. If blood is want to go to the aorta, it is striking at the AV wall, atrioventricular wall. Now we will start. This blood will go into the aorta. It has aortic wall has opened. Mitral valve is closed. It is opened. See, this is second heart sound. It is closure of the atrioventricular wall of the aorta. Thus you are listening the second heart sound, and you see the wave is going towards the base of the heart. This is base, this is apex. The second heart sound is going up. First heart sound was going down. At the apex area, it was going down and it is going up. And by listening the intensity, character of the sound, you can make out what is happening. Aortic second sound has increased. Told you high blood pressure. Aortic mitral valve first heart sound at the apex sound has increased. The patient may be having left ventricular hypertrophy. If the pulse has gone to the left side, the patient having hypertrophy, left ventricular hypertrophy, its impulse we had previously discussed. Now we are just discussing this sound. We are listening this sound with the stethoscope. At that time we just discussed with the fingers or hand. Is the point clear? It is just showing the complete cardiac cycle. Blood is coming, going. This is mitral stenosis. We will study little later. We have to see something else. Pulse. 1 minute. This is examination of the neck. Heart is pumping blood to the lungs. Heart is pumping blood to the arterial system. You keep the patient inclined at the 45-degree angle. Just keep two pillows, and then we will see what will happen. Just see, this is a carotid artery. This is your venous jugular vein. You can all detect your carotid artery here. You just put your finger here, inside, inner, no, inner, brother, this is trachea. You put it here. You can feel the carotid artery. Can you feel it? Yes. Can you feel it? When you are listening the sound, you have to feel the carotid artery of the patient. To know, you have to link the sound with the carotid artery. When the aortic valve will open, the blood will go into the carotid artery. Immediately you can find out with sound, you have to link the sound with the carotid artery. This is the clinical skill. Can you see the pulsation? This is normal. This is normal. In normal heart, normal person, you will see this pulsation. Then, if there is hypertrophic cardiomyopathy, how the sound will change? You see the vibration. I was just told. Okay. Hypertrophy is concentric hypertrophy, restrictive hypertrophy. There are three varieties of it. But in case of hypertrophy, you see by seeing the neck vessels, you can make out the patient is having hypertrophy. ये just giving the sound. Normally we don't listen to the sound, but you will actually see the pulsation in the neck. In the patient of aortic stenosis, aortic valve is narrow, and in the narrowing aortic valve, the blood has unable to go to the aorta. You have to make a lot of effort, and in that condition, you will see this aortic stenosis. Aortic stenosis, practically, if we see, it's a very incidence of this disease is very low. Normally, patient you detect it in a later age, in 60 plus, and patient doesn't have much problem. Aortic stenosis is not very common. As per my study and experience, I've seen cases of almost all variety, but aortic stenosis is very less. And this is the main aortic regurgitation. This is very common. I saw a patient 23 years of age. At a young age, this disease started. Aortic stenosis started very late age. Patient detected very late. It is, and one thing more, they die suddenly. One thing more, if the patient is doing exertion, चल रहा है, फिर रहा है, भाग रहा है, no problem. He feels better during exertion state. But you will see, you can detect the aortic stenosis patient, aortic regurgitation patient. He will enter in your office. You will find his shirt is moving. Shirt, whole chest moves because the blood rushes back from the aorta into the left ventricle. Rushes, force is so much. Again, suppose he has 50 ml blood. Pump, heart is pumping, out of 50, 25 goes ahead, 25 is left. Again regurgitation, the vein comes back. So the heart, left ventricle is full of blood always. In that case, you will see this. Not only this, you will see his radial pulse is also pulsating. So just keep your hand, you will see the radial pulse is pulsating. You check his blood pressure, the systolic blood pressure will go up and the diastolic will come to, you will say it is 0, but it is not 0. You have to train your ears to listen where there is a muffling of the sound is there. Now, systolic is 170, 180. Diastolic, you can say even in 0 it is still good. I am listening to the sound. Normally when the diastole starts, the sound is stopped. The sound is not stopped. So we have to very carefully see where the muffling, muffling means change of character of the sound is there. And that is the diastolic blood pressure. So it is very easy to detect aortic regurgitation. You are listening the blood vessels, listening the radial artery, seeing the radial artery, checking the blood pressure, immediately you can detect it is a case of aortic regurgitation. There is no need of any investigations. So this is by physical examination, by these skills, we can find out these three hypertrophic, aortic stenosis and aortic regurgitation. Hypertrophic and aortic regurgitation is very common, aortic stenosis is not common. Now we come to the veins. Can you see the venous pulsation here? On the right side, venous pulsation. Normally, you will see very little venous pulsation. Now you see how different clinical condition this pulsation changes. Suppose patient is having right ventricular hypertrophy. See clear closely. Why there is a right ventricular hypertrophy? There is congestion in the venous system, whole of the venous system. Lungs, they are full of venous blood. Our right ventricle has to make lot of effort to send blood to the pulmonary vasculature. In case of right ventricular hypertrophy, the venous pulsation is clearly visible. Not only venous, you will see the veins, they stand out like anything. Making patient lie down and you see the full veins, itni moti moti, thick veins. Immediately you can say the patient is in pulmonary arterial hypertension, or you can say right ventricular hypertension. These are all synonym terms. Another is tricuspid regurgitation. See the neck vessels. I told you where is the right ventricle. I told you right tricuspid regurgitation. Where will you listen? You remember? Lower left sternal border. Lower left sternal border. This is lower left sternal border. You put this stethoscope here, you will listen the sound. The sound which you are listening, you will see it in the lower left sternal border. I told you three sounds there. I told you sound of VSD. I told you sound of tricuspid regurgitation. You see the sound. Tricuspid regurgitation. Right ventricle, right atrium to right ventricle. This is the tricuspid valve. Blood, right ventricle is pumping. Want to send blood to the lungs for purification. Unable to do. Pressure is very high. What he will do? Is pumping, it will go back to the right atrium. And you will listen the tricuspid regurgitation sound in the lower left sternal border. If you find the veins enlarged, if you find the sound in lower left sternal border, immediately you can make diagnosis that he is having a tricuspid regurgitation. You will listen in mitral valve disease. We were discussing in mitral valve disease. We are just priming you for the disease condition. This is pericardial tamponade, pericardial constriction. I have not seen these cases, but if you want to see because normally these are ICU cases. Sometimes they don't come to us. I have not seen this. This pericardial tamponade means there is a pericardium, heart covering. If there is a fluid in that, then this thing will occur. But as for education, you can know, but I have not seen that case. Pericardial tamponade or pericardial constriction. This is very common. Right ventricular. This you will see in these cases. This pericardial constriction is there. In that position, you will see this palpation. This is actual patient recordings. This program is made in USA by Dr. John Pillay, and he made this actual patient recording. In the year 1996, 30 years back, I got this subscription for this teaching hospital sitting at Ambala, and they send me all these 4 or 5 programs to learn, self-learning programs. And he has written in his introduction that there is no need of doing different kind of echocardiography, angiography, and other things. You can, using your eyes, you can detect the patient condition. we will add on it ECG. Okay, what will be the ECG changes? We can record these changes. Ab dekho, you just see, this is ECG changes going on. They have recorded that also. You can see the JVP, jugular venous pressure changes they have recorded. Jugular venous pressure. They have recording system. They have record what is the jugular venous pressure. Because I have not this is PAC, premature contraction, premature. During his, I have not studied that, but they even record the venous pressure. They have instruments to record, but we don't need it. We are only concerned with the diagnosis, a correct diagnosis. We can write down diagnosis. We are not to accept the diagnosis of the allopathic hospitals. No, I will not accept. I will write my own way, my own clinical examination. I will see what is the condition of the patient. Because in allopathic hospitals, there are sometimes misuse of the technology. Immediate operation, immediate ICU admission. Patient is not that. You have to make, we have to work ahead of them. We have to go rise above of them, because when their cases fail, they come to us. Doctor, is there any help? They have refused us. No operation is not possible, or I don't want to. In that cases, we have to help the patient. And our medicines are wonderful. They are dynamites. You can help the patient. This is my experience of 30 years I am going to share with you. Right ventricular hypertrophy, not left, right ventricular hypertrophy. We will see the, in cases of pulmonary hypertension, if the patient comes to us and we can detect these jugular pulses, you can immediately make a inference that he is having pulmonary hypertension. What is the cause of pulmonary hypertension? We will discuss later on. But the appearance of the jugular pulse is due to pulmonary hypertension. We have no instrument to check pulmonary hypertension. But when seeing the jugular pulse, we can know the patient is having pulmonary hypertension. Here is very interesting. You see the jugular pulse pulsating. Clear. See very clear. You see very clear jugular pulse. This is jugular pulse pulsation. You are listening the sound. Hollow systolic murmur. HSM. Hollow systolic murmur. In case of mitral regurgitation, mitral valve disease, which we will going to study further, you will listen the sound hollow systolic murmur all over the chest, all over the back. In case of mitral valve disease, you will find all the chambers are enlarged. Something we will study, but the murmur you listen, this is hollow systolic murmur. Hollow systolic murmur. It is present in all the compartments. Murmur and sound, they are different things. Sound is normal, murmur is abnormal. Hepatojugular reflex. What is this? See what doctor is doing. You are putting your hand and pressing the lever. What will happen? There is no space in the right ventricle. Venous blood want to go to the right atrium from the upper side, and from the lower side venous blood want to go to the right atrium. No space, already full, traffic jam. We are just pressing the hepatojugular reflex. When you press the lever area, and you will see what will happen. You see that your you can see very clearly that this vein is engorged. You can see very clearly vein is engorged. What is here? The blood which was to go to the right atrium, it is going back into the venous system, and you can see the engorged vein. You see this arrow. Can you see it, Doctor Satvi? You press here and you can see this. Hepatojugular, it is called as hepatojugular reflex. Then this is hepatic pulsation. You see the liver is pulsating. You can see the pulsation. Hepatic pulsation is there in this case of whenever there is congestion in the venous system, central venous congestion, it's called CVC, central venous congestion. You can even see the hepatic pulsation. The liver is pulsating. He wants to send the blood to the heart, but unable to do it. So this is one observation which we see with general inspection. We are not touching the patient, just inspecting. This is apex beat, where I was previously talking to you. Apex beat. You press it like this with two fingers. Whatever you do it, no sir. Press it with two fingers. Left hand you press it. Make it. You can do it this angle also. You can feel the movement. Hypothenar muscles. You can feel the movement. You can detect the apex beat, and the patient will be in the left lateral position. You can check the apex beat. If there is a normal person, it will not be so strong. But in case of hypertrophy, you can actually even see that the apex of the heart is pulsating. You can actually see even by the touching. You can actually see it. They have shown the different pressures, or they have recorded the pressures of the. This is normal pressure. This is aortic stenosis. We don't need all these things, so we'll go ahead. The one is physical appearance. It is in central cyanosis. In case I was discussing with you ventral septal defect, tetralogy of Fallot. In that cases, you can see the cyanosis in the lips, in the tongue, or in the nails, different places. You can see even in the eye. You can see here. We will discuss it later on. Introduction to auscultation. Chest wall anatomy that we have already studied. Introduction to phonocardiogram. If you this you should learn. This is very important. This is low frequency sound. Sounds are of different qualities. One is low frequency, one is high frequency. What is low frequency sound? The first sound which we are listening at the apex, normal sound, is a low frequency sound. It is not high frequency. It's low frequency sound. And the next will be, this is high frequency sound. The sound of the second heart sound, which is listened at the aortic area, is high frequency sound. This is it. This is murmur. This is murmur sound. In disease conditions, we will listening the murmur sound and different time. low frequency, high frequency, and the murmur sound. And murmur are also different varieties. I have I have shown you the holosystolic murmur. This we will see in the mitral valve disease case. Holosystolic murmur. This point is clear. Let's go ahead. Hemodynamics we don't need. This is important. Cardiac imaging modalities. X-ray. We must know how to see the X-ray. This is normal X-ray. In the normal X-ray, you will find that the heart is in the mid position, and the heart is one half, less than one half, not one half, less than one half of the total transverse diameter. The transverse diameter is from this point to this point. You see the X-ray, you measure what is the transverse diameter, and if the heart transverse diameter is less than, it should be less than half, not half, less than half. If this, we will study further in another X-ray, I will discuss with you. If this diameter heart increases, whether this side or whether this side, it means heart has enlarged. If it has increased to the right side, this right ventricle hypertrophy. If it has gone to this side, the left ventricle. Not hypertrophy, first is dilatation. There are two aspects. One is dilatation of the heart and one is hypertrophy of the heart. Whenever there is increased physiological demand or pathological demand with the heart will dilate itself. Heart has a property to compensate with the lion. In disease condition, patient will come to you 42 years of age. All the heart walls are in bad condition, sclerosed or this thing or the immediate wall replacement. Doctor, I was well 1 month back. Now they say all the walls are disturbed and we need to all transplant, change them, wall replacement. He did not knew that disease is progressing in his body for 20 years. He does not know. The heart has compensated to the lion. This compensation of the lion is amazing capability of the heart. It will not allow you to know that your disease heart is problem is developing, and patient problem is detected at the age of 42 or 45 when all the heart walls are diseased. Now you study this. The right atrium forms the right heart border. Right atrium. If you find X-ray that this shadow has enlarged, it means the right atrium is enlarged. In case of mitral valve disease, is one example I am showing you. The other example also, suppose heart failure cases. Mitral valve disease is not there, but heart has failed. In that case also the shadow will enlarge on the right side. But the main thing is the right atrium has either dilated or it is enlarged. So this is you must remember, the right atrium forms the right heart border. Then this is the left ventricle. Right ventricle is there here, left ventricle is this place, and the left, where is the left atrium? Where is left atrium? Behind. We don't see. It is behind dorsal chamber. It is on the back. But this picture you should always have in your mind. Okay, this border, right heart border, means with the right atrium. Left heart border is made by left ventricle. If the shadow goes to the left, it means the left ventricle is either dilated or hypertrophied. both things can occur. Dilation is also two types. Dilation is either in the beginning, in the starting, patient may not be having not much symptom, and we see in the X-ray that heart shadow has increased on the left side. We can see that either there is a hypertrophy or there is dilatation. But X-ray gives us a clue that this problem might be going on in the heart. And this is pulmonary artery. In case where there is a left atrial enlargement, you will see the shadow will increase here also. We will study in further X-ray when we study the mitral valve disease. Now he has shown this thing. Now he has shown this is the ascending aorta, this is the pulmonary artery, this is mitral valve, left ventricle, right atrium, aortic valve. Aortic valve is in the center of the crosshairs. Center means if I draw a line like this on the X-ray, central point will be the aorta. Central point, crosshairs. X-ray, you take the X-ray and make two lines, hypothetical lines. Not draw. Hypothetical, you will see the crosshairs. The vital aortic valve is said to be in the center. This is I am priming you for the diseased X-ray, but this is normal. This is not abnormal. This is normal. Again, I have removed one layer. Now this is aortic valve. This is left atrium. Here you can see left atrium. It is behind it. When we have removed the upper covering, then you can see the left atrium. This is the ascending aorta. This is mitral valve. This is left atrium. Layer by layer, here I have shown the things. Should I repeat, doctor? Repeat? No. Thank you. In normal first and second sound, you can again repeat just to refresh. This sound is going towards the apex area. This first sound. This second sound you see in the aortic area. This is normal, not abnormal sound. We have already studied it, so let us leave it. This is murmurs. The murmurs are of these different varieties. Early systolic murmur, hollow systolic murmur, mid systolic murmur, and late systolic murmur. Systole. What is systole? Systole starts when the aortic valve opens. So there are different variety: early systolic, hollow systolic, mid systolic, late systolic. Hollow systolic murmur, I have already shown you. We will listen it further. But this is a hollow systolic murmur which we see in cases of mitral valve disease cases. Hollow systolic murmur. Don't be fearful with the murmur. There is a lot of sound coming. Patient is in serious condition now. When the patient is in serious condition, there will be no murmur, because the heart has secondary dilatation has taken place. Here the heart muscle is having strength. It is vibrating. We listen murmur because the heart blood vessels and the heart muscle is vibrating. When there is no vibration, secondary dilatation has taken place. In that case, you will not listen the murmur even, because secondary dilatation has come. In that condition, the patient is very serious. When listening the murmur, you see the heart is this strength. This is a very clinical point I am telling you. Primary dilatation and secondary dilatation. Secondary dilatation when the you are unable to listen the number, but the heart is dilated. You are seeing the X-ray. Whole of the chest is filled with cardiac shadow. Lungs you are not able to even see. Small lungs are there. So heart is dilated, hypertrophic, and the secondary dilation has taken place. In that condition, you will see what the X-ray. I will show you that X-ray also. I have got with me. I'll show you the X-ray. I used to record patient X-ray with me in my scan. I brought that X-ray also. I'll show you. Now we have come to the catalog of lesions. This is normal. इसमें you can see this blood is going from the left atrium to the left ventricle, and the next stage is first is rapid filling, second is diastasis, third is atrial systole, fourth is mitral valve closure. Again, aortic valve has opened and aortic valve has closed. If you play all, then you can see all the complete cardiac cycle. Blood is coming from left atrium to left ventricle in 3 stages. Then aortic valve is opened. Then it is going to the. This is normal. This is normal functioning. Now we have come to the valvular lesion, the most disease condition. After knowing all the normal things, we have come to the disease condition, and today we will study the mitral valve disease. He has shown the pressures: left atrium, left ventricle, aorta. This is normal pressure they are showing. Mm of mercury 40, 80, 120. 120 is normal BP, high pressure. This is acute mitral regurgitation. If there is acute mitral regurgitation, you see the pressures are increasing. Let's go ahead. We are not. Now we will see this thing. We are studying severe mitral regurgitation. Severe mitral regurgitation. Listen the sound. This is holosystolic murmur. This is very loud murmur. And you can see all over the chest and the back. You see. You can see this left atrium has enlarged. You can see the left ventricle. You can see this aorta. And you have just listened the sound. In mitral valve disease, we will regarding this thing, I want to tell you some clinical points. One clinical point is that mitral stenosis cannot occur alone. Whenever there will be mitral stenosis, there will be mitral regurgitation also. There is combination of lesions. If the valve is not diseased, valve is diseased, it will be stenosed, and at the same time it will regurgitate also. Left ventricle will pump blood to the aorta, but it is going to the left atrium. I'll show you that. It is going to the left atrium instead of going there. because there is a leakage. There are combination, and along with this, single valve is not disease. There are combination of valvular lions. What are combination? Mitral regurgitation, aortic regurgitation, tricuspid regurgitation. All the valves are disease, not working properly. Aortic valve is combination of the mitral valve disease and the aortic valve disease. It's most common. In case of endocarditis, why the valve has become diseased? Patient has history of rheumatic fever. 20 years back, 20 years back he had rheumatic fever. In that rheumatic fever, there is a high temperature, 102, 102, 103. It continues for weeks. They give salicylates, paracetamol. It comes down, it can go and go. And along with the fever, there is pains. In children, there are growing pains, muscles pains. In adults, yes, rheumatic fever can take place at any age. And chronic infection has established in the patient, and the rheumatic fever, there is a effect on the synovial membranes of the joints and the endocardial membrane. And gradually over the years, 10, 20 years, the walls become sclerosed. Obviously, the calcification has taken place. Calcification means degeneration. And there is another clinical variety. It is not in every case. If the patient has a rheumatic fever history, in that case, I have seen that the lung disease will also be there. Combination of diseases. I first taught a combination of lions. Now I am talking of combination of diseases. Lung disease will also be there in case of mitral valve disease cases. This I have observed in hundreds of cases. What are lung disease can be there? It can be pulmonary fibrosis. It can be pulmonary incipient or latent tuberculosis. It can be some asthmatic condition. There are other diseases of the lungs are also associated in the case of mitral valve disease case. Heart is not alone. Lungs and heart are both one unit. There is another variety that I am telling you from my experience. The mitral valve disease cases associated with renal disease. Face will be pale. You will find anemia is there. So there is a link in our body. There are combination of diseases. Heart disease with lung disease. Heart disease with renal disease. So you have to discover all these things. If there is a lung disease association, what will happen? You will see that his face has become black. There is insufficient aeration in the lungs. Photo, he will show you photos, doctor. That was so good, so nice, fair. Now you see the face has become black because lungs are unable to purify. Immediately you can make out he is having lung disease also. Then there are study further. The general musculature. There is a atrophy of the general musculature. Study the case. With so many systems in our body are linked together with the mitral valve disease. If you know the complete picture, in-depth clinical insight of the patient, you can know the character of the disease enemy. Disease is enemy. And we strike the dynamite right at the root. We make him comfortable. We will make him smile. Yes, you can see. But you see, the blood is coming back. I put label over it. You see, left atrium. This is, let's go, slow movement, slow movement. Previously we were seeing high movement. Now your movement is slow. They put a catheterization. They're putting a dye on the ventricle and showing you the regurgitation of the blood. Murmur you are seeing is holosystolic murmur. You have to make a link of the observation. Different links I have told you. You have to make link of the observation and your diagnosis will be correct without doing echocardiography. You will wonder in all allopathy system, patient comes to them, they don't check. Immediately listen some sound, go for the echocardiography. Because there is machines available. We don't have machines. Neither we are going to buy echocardiography machine. We have to use our own eyes, ears, and the third eye of the mind also. Apply the mind and link the observation and find out what is going on in the patient. Okay, label you can see again. This is left ventricle, this is aorta, this is left atrium. The blood is going back into the left atrium. Regurgitation is taking place. Again, show you. There, you say it needs to go to this side. It needs to go to this side where my arrow, but it is going to this side out. It should not go. Mitral regurgitation. Is it clear to you? Mitral regurgitation. Now we come to atrial. You see, now see we are recording the ECG. In case of mitral regurgitation, you try to count his pulse. You won't be able to count. You won't be able to count because you see the ECG. You see the wavy lines. You see the wavy lines. We will have some session on ECG. This is, he has shown the ECG. Heart is, we will study further. Heart is in enlarged condition. Left atrium is enlarged. And you, in that condition, there are different centers, excitable centers have come up. I'll show you the ECG also. But just see, in the case of atrial, this is atrial fibrillation. Fibrillation. What is fibrillation? It's muscle. We study in muscle disease. The heart muscle is diseased. It is fibrillating. And the ECG, you can see the wavy lines and you cannot check the pulse. Atria are beating at the rate of 200 plus, 300. Pulse is not going, but ventricles are not beating at that rate. It is distorted vibration, distorted pulsation of the atria, atrial fibrillation. Muscle has become diseased. Enlargement, you will see, I show you how much atria enlarged. This point is clear. Murmur, you can see this one. Now we have come to the X-ray. This is X-ray of the patient on severe mitral regurgitation. Hani Doctor Sahab, can you see the heart has enlarged? On the left side, you can see it is on the right side also. You see the picture. There is enlargement of all the chambers. Right atrium, right ventricle, left atrium, left ventricle, all the chambers are enlarged. And you see the X-ray. X-ray does not cost much. 500 rupees, you can get the X-ray done. No need of any big machines. You can see the X-ray, you can listen the sound, you can see the hepatojugular reflex, you can see the neck veins, and you can know what is the clinical condition of the patient. I have not added general or particular symptom. We are just adding knowing the common symptom of the disease. Common symptom. Clinical diagnosis will be correct, which no hospital of India or abroad can challenge you that your diagnosis is correct, incorrect, without doing the 80% cases, 10 out of 8, you can make the correct diagnosis if your clinical skills are very high. I cannot tell you the by examination the heart is working how much, 20%, 30%, I cannot tell. But we can diagnose. We are not concerned with that. We are more concerned with the clinical condition of the patient. What are his problems? Can you make him comfortable? Can you diagnose the case? 80 to 90% cases, patient comes to me with the files. Okay, keep it here. I check him, write the diagnosis. Okay, you have got this problem. Yes. Doctor, you are very correct. You have not even checked it. You have not seen the file. They do angiography, they do echocardiography. Then they tell us what is the problem. And you have done it. He will have so much faith, so much confidence in you. Doctor, मैंने operation नहीं कराना. I want treatment from you. And you can make him feel better the moment he leaves your office. Even he has not taken the medicine. Fear of disease will go away. His face will smile. He will have that confidence in you. The doctor is very good. I will get well. And in case of this heart enlargement, when all the chambers are enlarged, no doctor gives surgeries. Patient will die. But you can help him. Even this stage, I will show you the X-ray. When the patient heart is full X-ray. The lady came to me in 75 years of age. Already he has gone for surgeries. Mitral ballooning has been done, small replacement has been done. They could not help. All the ballooning and all the surgical things going on in the cardiology are zero. Why I am saying zero? When you will study this, you will understand what they do in the surgery, what patient problems he face after that surgery. You will wonder at that. Because of the homeopathy doctors who are not trained to learn all these things. So our medicines are lying in our pocket, just waste. If we learn, if we are educated, if we can master these clinical skills, you can deal with every case. This is a guarantee of Master Hahnemann, not me. Today is his birthday. He has given in the writing, follow my path and you will see the success. Whatever is given in the organ, whatever given in the coin, we don't need much medicines. If you master 10 to 12 medicines, you can help 80% of the cases. But those medicines has to be mastered. They have to go through every detail. You can never learn sulfur, you can never learn carbohydrate, you can never learn sepia unless you learn the original writings of the Master Hahnemann. You can never know Balsatla, you never know Stuja. Nobody even buys those books, nobody even reads that books. I bought these books, I read the books, read 2 pages a day. We can have some medicine seminar of medicines and we'll show you how we can learn from the original writings of the Master Hahnemann. And if we know that thing, I just told you the case of Pulsatla, I did 50% hard working. You read Pulsatla Materia Medica Pura, your eyes will be amazed. What a beautiful, he has written it. But generations have passed, people are unable to even see those books. Very difficult. 25 pages Pulsatla, who will study? You must study. Your own brother, your own sister, your own son is in suffering. A man, we are celebrating his birthday. Let us take a pledge today that I'll read 2 pages. Read one medicine, you will get connected to Dr. Henneman. You will see he is sitting with you. I, I have experienced it. This is my personal experience which I am going to share. And then the patient will come, he'll come and sit on you, beside you. Oh, I am with you. Go, do it. You will wonder at the result. Whatever success I have achieved, it is all the blessings of the Master Henneman, which I have studied prayerfully, not reading, prayerfully. We are celebrating his birthday today. We are doing prayer. That we go in a temple or gurdwara. We have created a temple here of learning. We are thankful to Dr. Sharma ji, who has made this wonderful arrangement for the scientific advancement of homeopathy. The scientific advancement. The we are listening the sound at the apex area, hollow systolic murmur at the apex area. We are now listening at second left intercostal space. What will we listen? Almost the same sound, not much difference. If you listen here, this slight difference, but sound is almost the same. He is given one X-ray here also that I will see. They have shown the calcified mitral annulus. Achha, in case of mitral valve disease, one thing more I am sharing with you. There are two type of cases. In one type of case, there is organic changes in the valve, and another is relative mitral regurgitation. In that case, the cusps are not diseased. You are listening the sound of mitral regurgitation. Valve was not diseased. Valves are healthy, but why there is mitral regurgitation? Because the ring on which the attached cusps are attached, that ring has dilated. Because there is dilatation of the heart. Due to dilatation or due to muscle disease, the ring has dilated and the cusps are unable to close itself. It is called as relative incompetence. This door is not closed. It is left open. Because if its framework is in a bad condition, the door will not close. That is relative incompetence. So you have to differentiate also whether there is relative incompetence or the organic lesion has taken place. We will study further. We will be able to differentiate between the organic lesion of the mitral valve and the relative incompetence of the valve. This is a clinical point. I've done very research in many books and studied thoroughly the patient, and these things you will not normally find in the books. What is relative? What is the mitral regurgitation? They have given me PGI or Fortis as called or replacement. Or he is having only the relative incompetence of the valve. There is no need of it. The patient was having some lung disorder. The patient was having some incipient kidney disorder. And in that condition, there is some dilatation of the heart has taken place. And you are able to listen the mitral regurgitation sound. But the valve was not diseased. There is no need of mitral valve replacement. The combination of the lesion, combination of other diseases, combination of other systems. If you go thoroughly examine the respiratory system, other system, anemia, other things, you will know what are the other causes of mitral regurgitation. Mitral regurgitation has got other causes also. Those other causes are also to be studied thoroughly in the patient and make it a perfect diagnosis whether the organic changes have taken place or it is just a relative incompetence. And you can easily cure the patient. This is actual photograph of a patient. Uh, Her name was Mary Peter, and she was having multi-wall disease. I gave you a reference that I cured one case of multi-wall disease. Three walls were affected: mitral valve, aortic valve, tricuspid valve. Almost all the walls were affected, and you just see the patient, see the face. What do you see in the face? You see that the cheeks are depressed. It's cured. The face will be pinched face. The muscles, the face, facial muscles, they were atrophied. Muscle wasting has taken place. This muscle wasting is not only in the face, it is all over. Neck muscles, arms muscles, chest muscles, abdominal muscles, leg muscles. This generalized muscle wasting in case of mitral valve disease cases you will see. Generalized. One thing I told you that it is the combination of diseases, heart disease and lung disease. Along with that, you will see there is generalized muscle wasting. They will show you lean and thin patient. He will not be flat and plumpy. If case of mitral regurgitation, relative variety. I told you two variety, organic and relative. In relative variety, the patient will be plump and rosy. He will not be thin, मोटा ताजा होगा. His weight will be good. In case of organic, you will see that his muscles, there is generalized wasting of the muscle from head to foot. Only seeing by face. It took me 2 years to heal this patient. Echocardiography was done again, it paid PGI, and they said no, there is no need of any surgery. Took me 2 years, but I could help him. Every month she improved. She was a teacher. She came from Mandi area, Himachal Pradesh. I treated this case from year 2000 before, 26 years back. But it is a very marvelous cure of the homeopathy that I have showing to you. I have again shown you the difference between the relative and the organic by seeing the patient. And one thing more, you will see the dark shadow complexion. In case of relative, there will be complexion will not be dark shadow. Complexion will be good. But you don't need to be see inside the wall. By reading, you should read the face. The patient you enter here in the office, you should be able to diagnose what is going on. Face reading is every line of the face you must read in cardiology.
Features and diagnostic clues for mitral stenosis, a condition often linked to rheumatic fever. Cardiac contour changes, bulging on the right, double right heart border, and left atrial appendage prominence signal left atrial enlargement. Radiographic clues, elevated left main bronchus, upper lobe vein prominence, and basal septal lines indicate increased pulmonary venous pressure. Diagnostic steps. Assess heart borders, carina angle, and look for mitral valve calcification. Chamber enlargement patterns. Left atrial enlargement is a hallmark, but other chambers may be affected by different conditions. Understanding these features helps clinicians quickly identify mitral stenosis and related complications, supporting more effective patient care.
This is a podcast I have made for the mitral stenosis. Listen further. One more podcast explaining it. This is a little longer.
When the valve between the left atrium and left ventricle gets narrowed. Usually this is because of rheumatic fever, which often affects younger people after a throat infection.
Right, and because the valve is narrow, blood has a harder time flowing from the left atrium to the left ventricle. It's like having a crowded room with a door that's too small.
Exactly. So the left atrium has to work harder, and over time, it gets bigger. This enlargement actually changes the heart's outline, which we can see on a chest x-ray.
Speaking of x-rays, there are some key signs doctors look for. One is the left heart border, which normally curves inward just below the left lung's main blood vessels. But with mitral stenosis, that curve straightens out, or even bulges outward.
And there's also something called a double right heart border. That's when the enlarged left atrium creates a second shadow next to the right heart border on a well-taken x-ray.
Oh, and don't forget the bulging of the left atrial appendage. That's a small part of the left atrium that sticks out more when it's enlarged.
Plus, the left main bronchus, which is the main airway on the left side, gets pushed upward by the enlarged atrium. And the angle where the windpipe splits into the two bronchi, the carina, normally is less than 90 degrees, but it widens beyond that with left atrial enlargement.
Those are really useful clues. And why do these changes matter? Well, the enlarged left atrium raises pressure that pushes back into the lungs, causing fluid buildup called pulmonary edema. That can make breathing difficult.
Yeah, so spotting these signs early on an x-ray can help doctors manage symptoms before things get worse.
It's also worth mentioning that while mitral stenosis mainly enlarges the left atrium, other heart problems can enlarge different chambers, like the right atrium or ventricle, depending on the issue.
That's a good point. It helps doctors figure out what's going on based on which part of the heart looks bigger.
So to wrap up, a simple chest x-ray can reveal a lot about heart health. Mitral stenosis is a great example of how changes inside the heart show up on imaging and why understanding these signs is so important.
Absolutely. It's fascinating how much we can learn just by looking at the heart's shape on an x-ray.
Thanks for listening. We hope this gave you a clear picture of mitral stenosis and its key signs.
Yeah, thanks. Take care.
Welcome to this episode.
This is the real X-ray picture of the patient, and we have made a podcast of to explain. I hope you must have enjoyed it. Today the technology has changed. We can make learning fun. Learning is fun, not a pressure. And it fixes in your mind. Whenever you see the X-ray, you can immediately make out that this can be the diagnosis. And the patient will wonder at you. I have gone to so many doctors, big hospitals. He will find a difference in you. Your degree of DM cardiology will be awarded by the patient when he will be helped. This is a podcast I have told. You have one more thing I want to see. Just 2 minutes more. It's almost over. Normal X-ray. I was talking about normal X-ray. They shown the A and B. A is complete transverse diameter and B is, this is normal X-ray. You have to divide. B is less than half. Less than half. This is normal X-ray. Normal heart. You have seen the diseased heart X-ray. This is normal X-ray. This I have brought to you. Mitral stenosis you have already seen. This is the examination of the murmur. Put the stethoscope over the apex, and from there you have to move laterally toward the axilla. The murmur is going in that direction. Direction is given. Put the stethoscope here, and from here you move to the axilla. The murmur will travel in this direction. You have to see which direction murmur is going. Like aortic wall disease, murmur will go to the neck. Mitral valve disease, murmur will not go to the neck, it will go to this direction. This is the examination of the mitral regurgitation. Mitral valve. Put here and go laterally. I have studied many things from different places, so I got the picture. This is the aortic murmur. When the aortic stenosis is there or aortic valve disease is there, you see the direction of the murmur, in which direction it is going. It will go toward the blood vessels. You put the stethoscope here in the carotid artery, you can listen the murmur of the aortic stenosis. Aortic valve disease, the murmur you will listen here. In mitral valve, you will listen on the lateral side towards the axilla. This is mixed murmur. Mixed murmur. Different valves are. This is the most common. Whatever patient will come to you in later stage, it is detected in later stage. It is not detected in early stage. The valvular defects, you see the mixed murmur here. Different valves are affected at the same time. Because patient compensation has taken place, patient does not know, is moving, going to the office, going to work. Suddenly the symptoms start. Then they find out that all the valves are to be replaced. And he will come to you and I don't want operation. You can help him. This is the thing. It's very important to understand the changes which have taken place. Firstly, there is a left heart failure. Heart is unable to pump blood into the circulation. What will happen? It will go make blood pressure in the lungs. Lungs से blood are unable to come. It will affect the pulmonary artery. There will be systemic venous congestion. Lungs में there will be congestion. Then spleen may be congestion, liver there is congestion, renal is there is congestion, and this is back pressure changes. You have to understand, and back pressure changes will result ultimate into right heart failure. Right heart is unable to pump blood into the pulmonary system because it is already full. This is called as chronic venous congestion. This will occur in the case of mitral valve disease cases. Now this is heart failure. Heart failure cases, there is biventricular heart failure. Left failure starts from the left ventricle and then later right ventricle failure. The biventricular heart failure will be there in the case of mitral valve disease cases. You just see left ventricle failure, low output, overfilling of the left atrium because blood is regurgitating. It is unable to go into the left ventricle. There is congestion of the veins. Because the congestion of the veins, the strain fault on the right ventricle because right ventricle want to pump blood into the pulmonary circulation for purification. But there is already congestion, he cannot go. The blood will go back into the right atrium, and from back to right atrium there is a general venous congestion, right ventricle failure. Both the side heart is failing. Start from left, right, both sides are failing. The patient will be in a congestive cardiac failure because both sides of the heart is unable to pump. The heart failure condition comes to this is the case. This is the X-ray. You can see the X-ray. This is actual X-ray. 75 years age lady. She is already gone for the wall replacement, and you see the enlargement of the heart. Almost right atrium. You see where it has reached. It is touching the side of the chest wall. In that condition, she came to me. I have already gone पहले ballooning was done. Later on, wall replacement was done. No relief. And the heart kept on increasing. And you see in which condition she came to. She took treatment for around 1.5 years with me. Later on, she passed away. The condition was so serious. But I could make him comfortable to live for another 1.5 years. But you see the condition of the heart. If we cannot cure, still we can help the patient. Even after surgeries. This is actual X-ray of a patient Bhupinder Kaur, 75 years age. I have brought to you. It's a real X-ray of the patient. One thing more you will see in the cases of mitral valve disease, you see the accessory muscles of the respiration working. You see the neck, sternocleidomastoid, scalene muscles, because lungs are also affected. A sign of lung disorder. Accessory muscles of respiration will work when there is sign of lung disease. Because heart and lungs, both we are walking with two legs. One cannot walk with one leg. It will be definite there, heart and lung disease will coexist in case of mitral valve disease cases. You have to link the observation and you have to link the systems also. There is so much sound of the heart, we cannot listen the vesicular breath sound because they were overpassed. But you can see the movement of the chest. You can see the depression below the clavicle. You can see the supraclavicular fossa. You will see the degeneration of the muscles, wasting of the muscles. You can see the, I can show you the one more picture. This is a diagram which I made. Heart disease is a multi-system disorder. This is not a disease only of the heart. You check all the systems, you will find different problems in the different systems, and you combine all of them. You will see it's a multi-system disorder. In our homeopathy literature, so many medicine, digitalis, tropanthus, cactus, so many given. You give them, you won't get result. Because you are not understanding the real picture of the disease. Patient comes to me, so many bottles, slightly, we थोड़ा सा ले लेते हैं, few drops, I feel better. Then what happens? Psychologically, and you have to strike at the root of the disease, and you understand that it is a multi-system disorder. You won't be able to cure the patient as per the rules of the ordinance. So this I make a clinical respiration of examination of the respiratory system is also important in case of mitral valve. I think I have covered almost all the points. Let me check if something is left. Now this is one more case. This is you can see this case. You can see this lady, severe heart failure. There is ascites in the abdomen. You can see the arms, the muscles, they have atrophied. Can you see the chest? You can easily count every rib. There is generalized wasting of the muscles. Not only the heart muscle is sick, it's all muscles they are sick. We have to focus patient as a whole. We have not added in general and particular symptoms. We are just going for the symptom patient. And there is a pitting edema. Whenever there is a heart failure, you will see the pitting edema. The X-ray is also given. You can see almost heart shadow has filled the X-ray. This I brought from the standard books. I have tried to explain to you all the clinical symptoms, diagnosis, diagnostic skills, and understanding the patient as a whole to understand the real nature of the disease and what its branches, how it is affecting the other system. And if we know all the clinical understanding, you are definitely going to help the patient. This is my experience that I have shared with you. I thank you all for the patient listening. Thank you.